So here's an intriguing case we've got today. A 32-year-old woman presenting with a seizure and visual disturbances. Now, she's got a history of hemolytic uremic syndrome and hypertension, both of which give us a good bit of context. With symptoms like hers, we have to think carefully about the causes, as they could be linked to her underlying conditions. Let's break it down with the imaging findings. We've got an MRI here, and it's showing high signal changes in both occipital lobes and parietal lobes, seen particularly well on the FLAIR sequences. These changes are centered in the subcortical white matter, and there's a bit of sulcal effacement and mild mass effect as well. What stands out, though, is that it's bilateral and asymmetrical, which gives us the clue that this isn't a localized process. No midline shift, no extra axial collections. The rest of the brain looks pretty normal, so already we're narrowing down the possibilities. Given the clinical picture and imaging findings, our first thought is posterior reversible encephalopathy syndrome, or PRES. This condition is often linked to severe hypertension, which is what we see here. PRES is essentially a clinico-radiological entity, which means that both the clinical symptoms and radiological findings are crucial to making the diagnosis. Patients often present acutely or subacutely with visual disturbances, headaches, altered mental status, and seizures. In PRES, the underlying mechanism isn't entirely understood, but we believe it involves disruption of the blood-brain barrier. This causes fluid to leak into the brain tissue, leading to vasogenic edema. That's what we're seeing on the MRI. Interestingly, the blood pressure in PRES cases isn't always through the roof. Sometimes it's only mildly elevated, or even normal at first, though in most cases, hypertension is a big part of the puzzle. On imaging, the hallmark of PRES is the presence of cortical and subcortical white matter edema. We see this here in the occipital and parietal lobes, which are classic locations for PRES involvement. There's no associated mass or infiltration, which helps us rule out more sinister causes like tumors or strokes. When you think about common causes of PRES, hypertension is at the top of the list, as well as other conditions like preeclampsia, certain drugs, especially immunosuppressants like cyclosporin A or chemotherapy agents like bevacizumab, severe hypercalcemia, and autoimmune diseases like systemic lupus erythematosus or hemolytic uremic syndrome, which our patient has. Renal disease and severe sepsis can also trigger PRES. On the MRI, PRES manifests as white matter vasogenic edema, typically involving the occipital lobes, though other regions can be affected too. This edema is best seen on T2-weighted sequences, and FLAIR really brings out the conspicuity of these lesions. One of the reassuring things about PRES is that it's usually fully reversible with treatment, and this patient's follow-up MRI shows exactly that, near complete resolution of the changes after managing her hypertension. So, what about differentials? Well, we'd want to think about conditions like cerebritis or stroke, but the bilateral symmetrical nature of these changes and the fact that it involves subcortical white matter really points us towards PRES. There's no hemorrhage or mass to suggest a stroke or malignancy, and that further confirms our diagnosis. Now, the imaging features of PRES are fascinating. On CT, you'd expect to see low attenuation in the occipital lobes involving the white matter, and usually there's no enhancement unless infarction has occurred. On MRI, the classic findings are patchy, symmetrical, bilateral subcortical vasogenic edema, particularly in the posterior regions. PRES typically spares the gray matter, and hemorrhage is not a common feature, which helps differentiate it from other conditions. In this case, aggressive treatment of the underlying cause, namely hypertension, is key. Early intervention leads to full recovery in most cases, and as we see here, no long-term anticonvulsants are usually required. If caught early, PRES doesn't cause residual atrophy or gliotic changes, and the brain can completely bounce back. However, if it's not treated promptly, there's a risk of progression to infarction, and that's where the complications can start stacking up. As for the imaging features, T2-weighted sequences and FLAIR are your best friends here. They show the white matter vasogenic edema most clearly. Occasionally, more anterior structures are involved, but this case sticks to the more typical pattern of posterior lobe involvement. Hemorrhage is not common in PRES, which helps differentiate it from primary infarction with hemorrhagic transformation. Diffusion-weighted imaging, DWI, will show slight increase or iso-intense signal, and the ADC will be bright, indicating the presence of edema. The good news? PRESS is completely reversible if caught early, and as in this case, we're seeing improvement on follow-up imaging. The earliest reported resolution of these changes can occur in about 5 days, though in some cases it can take weeks to months for full resolution. Now, it's important to recognize some atypical imaging features of PRES. While the occipital and parietal lobes are the classic sites, sometimes anterior regions, like the frontal lobes, can be involved. You can also get cortical lesions affecting the gray matter. In rare cases, you might see hemorrhage, subarachnoid or intraparenchymal. Other areas like the basal ganglia, thalami, cerebellum, or brainstem can also be affected in atypical cases. And sometimes PRES can present unilaterally, though that's quite rare. Recurrent episodes of PRES can also occur, so it's something to keep an eye out for. So in summary, this is a classic case of posterior reversible encephalopathy syndrome PRES. The imaging findings: bilateral occipital lobe edema, high signal on flare, and absence of infarction or hemorrhage point strongly to this diagnosis, and the patient's rapid recovery with hypertension management confirms it. If caught early, PRES is fully reversible, which is what makes recognizing this pattern on imaging so crucial. If you're fascinated by these deep dives into radiology cases, don't forget to subscribe to Radiology Made Easy on YouTube and let me know your thoughts in the comments. I'd love to hear how you approach similar cases.